So welcome everybody. So this is our first work and health question time. So it's a new series of webinars that we've decided to put together. So the aim of the work and health question time is to allow all members of the council to come together and for us to sort of discuss topics of interest through sort of a multidisciplinary approach perspective. As many of you will know, that during the council meetings, we very often have a topic that will be presented that will be relevant to the time, but we don't very often get opportunity to discuss it. So the aim of these webinars is very much to take that, it's an extension of these presentations so that we can actually then discuss the actual practical implications and what it means for us in practice. So our topic today is that we're going to be discussing the changes to the FitNote and how this may influence occupational health practice. We have a great lineup on our panel. We have Cathy Roberts, David Long and Sarah Holt, of which I'm just going to hand over to them individually so they can provide a brief introduction of themselves. And then the process for this morning will be that we'll then have a bit of an overview from David from the DWP, and then we will open it up into questions, which we have some that we're going to ask, and then we will open it up to you all. So as Mandy said, please do keep putting your questions through into the chat as we go along, and then we'll have a section at the end where we can ask any additional questions that may have come through. So I'm going to open this up first of all. So David, would you like to provide just a brief introduction of yourself?
Sure, thanks, Nick. So hi everyone, my name is David Long. I work for the Department for Work and Pensions, and I have responsibility for the FitNote changes that we're discussing today. As part of my background, whilst I am DWP, and that's where the changes have been made in terms of policy and regulations, I actually work as part of a joint work and health unit that spans both DWP and DHSC. So it kind of dovetails into the shared elements around work and health, some of which we'll discuss today. But that's me, thank you.
Thanks, David. And Cathy, would you like to introduce yourself?
Yeah, sure. Good afternoon, everybody. My name's Cathy Roberts. I am a practicing occupational health physiotherapist. I've been in occupational health for quite a number of years now. Over the last 8 years, I've been the education officer for ACPO. Those of you who are not familiar with the acronym, it's the Association of Chartered Physios in Occupational Health and Ergonomics. We are a professional network from the Chartered Society of Physiotherapy. So through the work I've been doing for ACPO has included quite a lot of development work on education pieces. We've also been running some CSP funded projects on the FitNote and having work conversations, which I'll talk to you a little bit more throughout the webinar today.
Thanks, Cathy. And Sarah.
Hi everybody, I'm Sarah Holt. I'm an occupational therapist working in Derby. I run a service that specialises in vocational rehab within the NHS, primarily working with musculoskeletal patients.
Lovely, thanks very much. Okay, so I'm going to hand over to David now, and he's going to sort of set the scene a little bit for us in terms of giving us a little bit more information around the changes and the reasons behind why these changes to the FitNote have been made. So over to you, David.
Cheers, Nick. And I'll try and keep this brief. But to start with, I'll outline what the changes actually are. Then I'll go into a little bit of the background context, and then I'll give some further detail on FitNotes. And hopefully that will then set up and kind of facilitate the discussion. So as a starting point, the changes that we're talking about were 2 regulatory changes that were made earlier this year. So the first in April was that we updated basically the processes by which FitNotes can be issued, which enabled FitNotes to be completed, authorised, and then sent digitally, because previously they had to be printed and physically signed with a wet signature for them to be valid. In July, we then made what was the more significant change in expanding the range of healthcare professionals that can authorise and issue FitNotes. So previously this had always been doctors, And what we did was introduced 4 additional professions in the regulations, and these were nurses, occupational therapists, pharmacists, and physiotherapists. So they can now certify and issue fit notes in addition to doctors. Now, the background context to this is bigger than just the fit note. So this sits within the wider body of work around promoting the links between work and health, and that's really based on the growing body of evidence and kind of acceptance that there are strong links between work and health, and that there is a lot that's been published, and there's been a lot of commentary around the fact that good work is good for your health and well-being. So as part of the kind of wider body of work that my area sits in, our key aim is to really kind of promote and help disabled people and those with long-term health conditions to either access or remain in work. And kind of underneath that, there's a core element of that aims to help healthcare professionals embed high quality work and health conversations as part of standard day-to-day practice and interactions with patients. And obviously one part of that is the fit note. So it's just a quick summary into the fit note itself, in case people aren't aware. The fit note is a form of medical evidence. It's the main one that exists that's delivered through NHS services, and what the fit note does is basically supports people as a form of medical evidence for them to access either statutory or occupational sick pay for those that are in employment, or for those out of employment to support them making a claim to health related benefits. There's a lot of them. The data that we have for GP surgeries in England shows that roughly every year there's 10 million fit notes issued, previously obviously by GPs, and that was when it was only able to be signed by doctors. The fit note as it is now was introduced in 2010. Previous to that, it was called the sick note, and the real shift in focus in 2010 was a movement towards recognition of what people can do, and then the support that would enable them to either remain in or return to work more quickly. And that's the real driver behind the changes that we've introduced this year, is we want to see the fit note become an enabler for really supportive work and health conversations that helps people to do that. But I think what we need to really recognise is that the fit note itself is the output of a conversation, and the policy intent and the driver behind this is very much the quality of those conversations that professionals are having with people, that helps give advice so that they'll either remain in or return to work more quickly. So it was back in 2017 that government signalled that they wanted to reform and improve the use of the fit note, and one of the key elements of that was extending the range of healthcare professionals that can actually do it. And the kind of basis for that has been a real recognition in the shift towards multidisciplinary teams, and the incredible value that other professionals have in holding those kind of conversations and offering that direct support to patients. So hop, skip and a jump later, and that's where we've got to the point where we have extended that range of healthcare professionals in regulations. It's the 4 that I've mentioned has been the kind of first step for us, and this is a really significant change for government. When we're talking about medical evidence and where it's always been the kind of purview of doctors to be able to do this, stepping away from that for the first time has been a really significant step for government. So that's what has been in place since July this year, and like I said, the real driver is to support better work and health conversations. What I'll do is I'll pause there in terms of the kind of background context and summary of where we are. I think that's my sort of promised 5 minutes, and I'll hand back to Nick, because what we'd really like to see is a really good discussion around what that actually means in the clinical context and for people in terms of their practice.
Thanks, David. That's really helpful just to kind of set the scene for us. And I think we all sort of welcome this change in the sense of certainly promoting more people having work and health conversations. So in terms of opening up the questioning then, what I'd like to put out to both Kathy and Sarah to start with is, would both of you feel able just to give us a little bit of information around what your experience has been working in practice since the changes to the fit note have come into play? Kathy?
Okay, so what I'd say is there's been an increase in engagement with us as a group of occupational health specialists with the wider community of physiotherapists out there. We've been having a lot of questions coming to us about occupational health and having work conversations. So it's very much improved our engagements, and we've been seen as the experts to help support the wider community of physiotherapists who are working with the working age population in supporting them in how they should undertake these conversations. And it's really, it's boosted the profile of occupational health tremendously, which has been good for the profession. It's been good for generally getting work and health out there into general conversations and communication. We've had requests from primary care networks. We've been having requests from universities for both postgraduate and undergraduate training on the subject. So just by the legal changes, which has highlighted something that an action that the actual professional can undertake, that's led to a bigger and wider conversation with us, which has been extremely useful.
Thanks, Kathy. And Sarah, what's been your experience?
So similar in some ways. I think people are seeking to make contact, to try and find people who might be able to advise them. I've had contact from a lot of OTs working in primary care networks, new services. We were quite involved in long COVID rehab at the start of the pandemic, and we still run a long COVID service from this department. And lots of people now working in vocational rehab feeling as if they want to embrace the fit note and also feel like they should, but also a degree of apprehension about the level of expectation perhaps placed on them by GPs. They welcome, like you say, the opportunity, and they do think they've got the skills to do that, but I think there's quite a high expectation potentially. I think one of the difficulties when you work in a large organisation like I do, it's a large NHS trust, is how do we embed it into our IT systems? How do we get access to the eMed3? How do we have an agreement from a governance perspective? We don't ever do things in isolation when you work in a big organisation like this. Obviously, as I'm sure most people will experience, there's a lot of people who need to agree, set guidelines, set parameters. And I suppose it is about that understanding of level of expectation, that you don't fill out a fit note simply because you're one of the professions that's now allowed to do it, that you fill in a fit note because you have the skills and you have the ability to affect a change and make recommendations and understand how to predict timeframes. There's actually quite a lot to it. And I think just because we work in those professions doesn't mean that we've necessarily got the skills to do that. So there's been a lot of conversation about expectation, but also, like I say, people wanting to embrace it and wanting to take the opportunity to raise the profile of the profession and to show what they can do, but having the ability and the knowledge to do that.
Excellent. And have either of you been using the fit note yourselves personally? Kathy? Either of you?
I was hoping Sarah was going to come in there. So for my own personal practice, because I work in occupational health and I tend to write very lengthy specialist reports, I would say that it's the level of report that I write is above and beyond what you can put onto a fit note. So the only time that I would probably use a fit note would be if I'm actually wanting to sign somebody off, and that is obviously not what I want to be doing. So I would say I've actually not completed a Med3 fit note since the changes in July, because I just haven't needed to. In past years, I've used the AHP Health and Work Report, which is still available for allied health professionals who perhaps cannot get their hands on the Med3 fit note, because Sarah talked about the problems with the computer systems. Well, if you can't actually get onto System 1 or EMIS, you might not be able to complete the Med3. So the AHP Health and Work Report still very much has a place today. So I'm kind of waffling on. For me personally, the Med3 is not really going to change my personal practice. However, it is changing the practice very much of a lot of physiotherapists and other first contact practitioners working in primary care, because they are now able to have that conversation with the employer, the organisation, and with the specialist occupational health services. So I'm seeing other physiotherapists and other professional groups having conversations with me through the Med3 to me as an occupational health specialist, which has been very useful. Does that make sense?
Yeah, absolutely. Thank you for that. Sarah, have you got anything to add to that?
Only the fact that we have big issues, like I already said, so embedding it into our practice here, we're not permitted to just go ahead and start to use them. And, you know, and I think that obviously it will come much more to acute trust as we progress through. But like Kathy said, you know, we write AHP work and health reports every single day. You know, we treat really high volumes of patients, you know, and I think that in some respects, it actually allows you to have more detail, to actually make recommendations. We had an interesting conversation in one of our RCOT meetings about you know, making recommendations, and somebody said, well, you wouldn't necessarily make recommendations if you were signing somebody off work. And I really do think that you should, because, you know, you still should be saying, why is someone off work? What are you going to do about that? And I think the advantage of the work and health report is it allows you to identify specific difficulties, how that relates to work, and to make recommendations. You know, the challenge, I think, with the fit notes and the Med3, the e-fit notes is that flexibility to put the detail in that you would want to do. And like Kathy said, we're so much more used to writing detailed reports, functional capacity type reports. And, you know, so at the moment, there's two problems for us. One is does it allow us to put enough detail in? And most certainly are our trust going to progress with this, and how quickly they're going to do that. You know, we would like to be able to do them now, because I think that that's, you know, it's important for us and the profession going forwards, but we don't have it embedded in our systems, and we haven't got a governance agreement at the moment. Okay,
so there's some infrastructure around it that needs thinking about. I think, Mandy, you've got your hand up.
I have a question for you, for the panel, and quite timely it came in as Kathy was talking. It's from Lucy Booth. So in practice, I work as a physiotherapist advising employers and employees about fitness to work. So conversations about work are the focus of my assessments. My understanding is therefore that I am not in a place to provide a fit note, as I am not a treating clinician. Am I right? Is anyone else in this situation? Would you like to comment? Or who would like to comment?
Well, I personally see no reason, if you feel it's within your scope of practice to be able to complete the fit note, just because you're not a treating clinician, you've still got your assessment skills to be able to make decisions on somebody's fitness for work. So why shouldn't you be able to complete the report? I see no reason. If you are skilled at being able to have that conversation, finding out what the individual's work demands are, undertaking a clinical assessment, which may include some functional measurement testing, if you can marry the job demands that they have and the problems that they're having at work with their clinical pathologies and how they are when they see you, just because you're not treating them does not mean that you can't actually advise and put your input in, and to start that conversation with the individual employee and their employer, which is really what we want to see. We want to see the conversation being had between the employer and the employee, and we're helping facilitate that. So I see no reason at all why you can't complete it.
Okay, thank you. I've seen lots of nodding heads, so I think Sarah is in agreement with that. Is that right?
Yeah, I think there has been a lot of uncertainty, though, I think, with people working in that capacity as to whether that is part of their role, whether they actually have permission to do that work in that type of role, and maybe some clarification on that wouldn't be a bad thing.
Okay, so that leads me on quite nicely, really, to my next question, which is
I was going to add, because I might be able to add something on that.
Yeah, sure.
it may come down to the setting that the person is working in, and it's part of the nuance of the regulations. So far from me in a discussion like this to ever quote regulations at people. What it fundamentally comes down to is that the kind of the form, so the actual template, the Med3 template, whether the clerical version that can be ordered still directly from Department of Work and Pensions for people who can't access systems, or for those that can access it through the systems, which is the eMed3 that people have referred to. At the moment, that is limited to people who are delivering services in NHS settings, so those delivering NHS services. So if people are working outside of settings where it's part of the core NHS services, they won't have access to either the Med3 template on paper that they can still order, or the electronic version that's within systems. However, I think, and this is where it kind of dovetails into wider work around employer education, because that should not mean that person cannot provide advice. And I think, Kathy and Sarah, you've articulated that the difference is it fundamentally comes down to, if it's for things like statutory sick pay or sickness absence, ultimately the employer does have the choice as to what they request. And if the person is providing that advice and it's outside of the FitNote Med3 template, we have seen sometimes reluctance from employers to accept that, but really it shouldn't invalidate that advice or that conversation. It's just that the way that they record it won't be in the template that's provided for in regulations. And I think that's definitely an area that there's more work to be done on. But I think I would definitely agree with Kathy and Sarah in saying that it should still be a valid conversation. The advice is still very relevant, and in an ideal situation, employers would recognise that and use that in place of a fit note, and then not still require that person to go and get a fit note. And I think that dovetails slightly, Kathy, in some of what you were saying about the quality of those OH reports, where if that's being produced and a person has hold of that, you would hope that in the background an employer still didn't require someone, although they sometimes still do, to go and get a fit note that will have less information in it than that detailed OH report.
Thanks, David. So moving on to our next question, which I think flows on nicely really from our discussion, was to think about the training that's been made available since the changes to the fit note. So firstly, I wanted to ask Kathy and Sarah, from their perspective within their own organisations, what training do you know about, have you been made aware of or been involved in? And then perhaps from David, if you could then input on anything sort of on a wider scale around training for all the practitioners who are potentially a little bit unsure and not as confident about completing the fit note. So Sarah, do you want to start?
So from an OT point of view, I mean, the website, will direct you to the e-learning that's available for all professions. We've done monthly meetings that people can come to. There's a frequently asked questions section. There's webinars that have been recorded. There's another one that we're doing next week that isn't purely around the fit note, but will include the fit note. And there's plenty of resources at the moment, but I think that people still seek specific clarification already on some of the things that we've touched on. If I work in this setting, can I do it? Do we replace it, the fit note fully, the AHP work report fully, because that allows you to present more detail, so there's still quite a lot of things that people would appreciate clarification on, but I think it's evolving and it's developing all the time internally within the organisation, as in here and within NHS organisations. I think that's a little bit hit and miss at the moment. I think that most people are going to their professional bodies currently for the information that they require, or the DWP, or anything they can access nationally. But I think that there still needs to be localised agreements, and I don't think that's exclusive towards at all here in Derby and Burton. I think that it's something that people are seeking generally, is clarification on a local level from a governance point of view, what they can and can't do.
Thank you. Kathy?
So ACPO have been quite actively promoting work and health. We've secured funding through the Chartered Society of Physiotherapy physiotherapists to run different projects. And I think the first one was about 5 years ago, where we developed a e-learning module on work and health and the importance of having that effective work conversation. So that went out about 5 years ago onto the Learning and Development Hub of the Chartered Society of Physiotherapy. So anybody that's a member can go on. Unfortunately, non-members can't access that. But in the next year, so a couple of years ago, we then launched further workshops specifically for first contact practitioners in primary care. We ran probably about 15 different workshops, which was extremely useful because we got so much feedback from what the problems they were having as well. We developed these workshops, which really helped. Our outcomes showed that their confidence in actually having those work conversations had improved dramatically. We busted those myths about different things like the individual needing to be signed back fit to work after a period of absence, all the things that are commonly sort of misconstrued out there. So we really got very strong messaging to these first contact practitioners. Through that project, we also developed a learning management system that is free access to anybody. So we've got actually a lot of links on this learning management system, including the actual workshop that is recorded, so anyone can go on that and listen to it. And that's not just pertinent to physiotherapists, it's pertinent to nurses and to OTs as well. And on the LMS, we've got links to like the Health Education England FitNote training and lots of other sort of chats with GPs and different resources that can be utilised to really push the message forward about actually, yes, you can have these work conversations. And once you overcome sort of the myth busting and the confidence issues, actually the physios, the OTs are realising how well placed they actually are to have these conversations, and actually they can do it. You know, they can have these very good conversations and have a fruitful outcome. Their job is working out what their priority is within their session that they have as to how much importance they put on the work and health over, say, some other clinical input that they might need to have. So those two projects have gone down really well, and we're now on our third project, which is looking at improving the profile of what first contact practitioners and advanced nurses can do in primary care to the GPs. Because what we found is actually the GPs are a little bit confused about what's going on. They don't quite understand the role of the first contact practitioner, and that's leading to sort of some messaging issues to the patient. The patients are getting confused because the professionals are a little bit confused as to whose job is what. So we're hoping to engage with the Royal College of GPs and to promote some cohesion, shall we say, regarding the messaging of what's going on in primary care. So I'd say ACPO, we've done quite a lot, and the CSP themselves, on the CSP website, there's a load more resources as well to help guide physios and anyone who wants to go on the CSP website. A lot of it is accessible to all. So yeah, that's us.
So it sounds like there's been some great work going on across the organisations. But David, could you give us a bit more information about sort of training on a sort of a wider scale, perhaps across the different professions?
Yeah, absolutely. So we've obviously had to do this from sort of a central position. So the starting point for this has been the updated guidance that was published on gov.uk. I think we're going to share the links following this discussion. So alongside, and it was commissioned through Health Education England, and they helped bring together a working group. But we had a new set of guidance produced and published on gov.uk alongside the regulations that kind of helps give a steer on setting out for both the healthcare professionals themselves, but also their employers who can actually undertake the task. And that's really sort of the starting point. There's an additional set of guidance that was updated aimed at the healthcare professionals around using the fit note and how to issue it. And then dovetailed into that, which both Sarah and Kathy have referenced, a training product was created and launched on Health Education England's e-learning for Health hub. So there is now a bespoke fit note module. It's got 4 parts to it, and it covers the background, the kind of legislative context, work and health conversations, and that itself also links into wider, more expansive training that's hosted on the e-learning for Health hub around work and health. So there's a whole other set of products on that hub for kind of setting the foundations if people are really unsure in work and health and what the background is, so that they can develop an understanding. The way that we see it is that if you complete those, if you do the kind of background work and health training, the fit note modules, get to grip with the guidance products, and your employer has read those as well, it should put you in a really good place for understanding whether you can do it, but also whether it's right for you and what is necessary. In addition to that, we've then been working with the professional bodies and other organizations to look at, as implementation continues, supporting them in creating more bespoke advice and guidance for their professions where it's right to do so, because it does obviously differ in the types of roles and clinical tasks that they'll be undertaking.
Thank you, David. That's really helpful. I think, Mandy, you might have a couple of questions.
Oh, I do indeed. Just following on from the response to Lucy's question earlier, she says, just for clarity, I work in an NHS occupational health service providing detailed reports similar to the work that Kathy does. So we'll give more detail in a report than a fit note will provide. Is that correct? Is that her understanding?
Yep.
Yep. Okay. So we'll say yes to that. Then we've got a question from Val. As an OH physio, I am picking up on Med 3s that have little detail due to HCP completing a fit note, not having knowledge of workplace tasks, which I can imagine is quite a frequent thing. I mirror Kathy's response. Is further guidance required for those completing the fit note, I assume?
Kathy, do you want to take that one?
Yeah, what I'd ask Val is, do you know whether they've actually received any training? I mean, have they gone through, for example, the Health Education England e-learning? Have they gone through any training at all? Because certainly that's the crux of it.
Did we just get kicked out of Zoom?
Yeah, that happened to me, Mandy. I'm back in again now. So I don't know what I've missed, if anything.
I am so sorry. I have no idea what happened. My heart, I swear I wanted the ground to swallow me up. Oh, my apologies. I have no idea what. Does it do that? I've never had that happen to me before. Okay. I will investigate what happened later. That's just freaked me out slightly.
Teething problems, don't worry.
Yeah, it is.
It's fine. Thank you, Mandy. I did think it was just me, so I was having a panic then. So I'm actually quite glad it happened to all of us. So.
I think it happened to everybody. So hopefully we get everybody back. We have 2 more questions if you have time for those now.
Yeah, sure. Have we got Kathy back? Oh.
Not yet, no.
That's okay. Do you want to keep going?
Shall we just propose?
Yeah, I can answer any from her side.
An interesting one. Ronka has said, I do not work in the NHS setting. In fact, I work in Nigeria in a private setting, providing professional ergonomic services to organizations. Do I have authorization to use the FitNote? Some of the doctors are happy with the support it adds to their care. Don't know, David, maybe might be a question.
Yeah, I think you know, without understanding more of the kind of context and background, my initial take would be probably not, but that would be in the context of the FitNote template set out in regulation, so the MED3 itself. However, if you were to, again, you know, have those conversations, give that advice, the employers ideally should be in a position to accept it and not require, you know, someone to go and get a FitNote if it's applicable.
Yeah, I would agree with all of that. Kathy and Sarah, got anything else to add to that?
Yeah, no, I don't think I've got anything more to add, but you know, use it as a tool to start that conversation.
Yeah, I agree.
I think using the AHP work and health report, that structure would work really well, wouldn't it? Because it kind of informs your way of thinking and it's nice and clear. If you're not going to use it in its official capacity, it's probably better to use the work and health report than it would be the MED3.
Yeah, absolutely. It provides a nice template to work from, doesn't it?
Yeah.
Okay, Mandy, are there any other questions?
One more from Fiona. I work as an occupational health physiotherapist in a large NHS trust. I'm already aware that there may be some challenges around being able to embed the use of a FitNote within our department. Just wondering if the panel have any data on whether other NHS trusts have managed to implement the use of the FitNote in these areas.
Okay, perhaps Sarah, do you want to take this from your experience?
I don't think there's many at the moment that have got it embedded into their systems, but and interestingly, when we first started writing the AHP work and health reports, many employers, lots of employers just accepted it and didn't question it. And one of the few employers that questioned it was actually our own trust. So they posed more of a challenge to us than most places. And at the time, you know, certainly going into the pandemic, we were treating a huge number of staff that were suffering with long COVID. So once we actually got an agreement, and yeah, we still get bounce backs occasionally, but I certainly think if you're not already doing it, to start to use the work and health report regardless and use it as a tool. But I don't think there's many NHS organisations yet that have it embedded. And you know, we treat a lot of staff here. I also manage an occupational therapist that works within occupational health for the trust, and they're not using the MED3 as we stand at the moment. But certainly when we look at it as an organisation, those that are covering occupational health are certainly very much part of that conversation.
Okay, thank you. David, is there anything from a central perspective that's happening with regard to that?
There is. I think we're very aware, particularly that there are challenges with systems. You know, the ideal situation, as ever, and as things become increasingly digital, is that people have access to it digitally. So I think we've made really good progress across not only in Scotland and Wales as well in getting the new template and the access to the additional professions in place across primary care. I think the next step for us is looking at secondary care settings. But for those of you that work in those settings, I'm sure you'll appreciate how much more of a complex picture that is in terms of suppliers. Sarah, I can see you smiling. So that's something that we are working on, and it's one of our kind of key areas, is to, you know, embed the template fully so it's within systems. What I would like to emphasize again, though, is that for people working in those settings, as long as those kind of local governance conversations have happened, they can access, albeit the paper-based version, the clerical pads of FitNotes. A lot of trusts already ordered those and stock them for doctors. So whilst there is obviously still a transition while they get to grips with understanding how it works across other professions, there should be stocks, certainly of the new template, within those settings. So it might just be a case of either getting in touch with the right person or having an internal conversation, like you've both highlighted around governance, to make sure that people who are there who can do it and possibly are already doing it can actually access those as well. And if they haven't reordered stocks of the new template, that's done centrally.
Okay, thank you. I've just got a couple more questions that I would like to get through. I'm aware of time, so just the first one would be, I'd really like to get your opinions, Kathy and Sarah, in terms of for those of us working in occupational health, what do we feel sort of the impact of the changes to FitNote is going to be, whether that's positive or negative? But if you can share your opinions, that'd be great. Kathy?
Well, we know that I think the figures are about 50% of people have access to occupational health. So I would hope that the changes to the FitNote legislation actually sort of bridges that gap and gets some support in the early stages. And we know that that early support and putting people in the, getting them early and pointing them in the right direction right from the offset is really important. So I do hope that the FitNote changes will be the enabler that helps to support that to happen. And it's certainly improved the profile of occupational health. So I really hope that that dwindles down to sort of more occupational health being taught at an undergraduate level, more support to professionals in occupational health, because there's just not the grounding that there needs to be. So I'm hoping that this will help facilitate that to happen, and I think we're showing signs of that happening already. So it's got to be positive. We know that allied health professionals and nursing staff can be really good at having these conversations. So that needs to become normal practice. And that needs to be what the patients expect to be normal. And I think this is the start of a long road, hopefully, towards that.
Thank you. Sarah, have you got anything to add to that?
Yeah, I mean, it makes perfect sense, doesn't it? It makes sense that if you're having those conversations that you then provide the relevant paperwork. I mean, we, as well as running an NHS service, we also provide vocational rehab services to quite a large local employer. And they're very happy to accept FitNotes from us. But interestingly, when I spoke to them about whether they were intending to embed it into their practice as nurses, they didn't think that that was going to add value, which I thought was quite an interesting statement. Yeah, I think it's a tricky one, isn't it? I think it makes absolute sense for the patient and the pathway, the seamless approach, that it's all done. It seems ridiculous, doesn't it, to bounce back to a GP when you're the one having the conversation. Yeah. And I think it's a shame for us not to really push that. But I think that again, it's that understanding, isn't it, about whether they can do it, what the parameters are, and getting all those local agreements in place, and recognising that it absolutely does add value. I thought that was quite an interesting comment, that they didn't think at this point that would add value from a nursing perspective. And this particular employer, they obviously outsource their therapy, so they're very happy to accept it from therapists, but weren't necessarily intending to internally do that themselves.
Okay, thank you. Mandy, I think you've got another question.
I do, thanks so much. It's from Anne Harris. As a healthcare professional, I recognise the importance of education for competence. Others may not. Is the training mandatory, so only those who have completed the training can access the hard or e-copies of FitNotes?
Good question. David?
I mean, I'll try and give a concise answer on this. In essence, it's not mandatory, and part of that is recognition that there are other ways of learning, so that there'll be people embedded in roles who have a huge amount of practical experience of doing this. And if what it comes down to is the ability to show competence, and we've done a lot of work with the regulators and professional bodies to articulate that. So if someone can show competence, then they should be able to do the task. One of the ways of showing competence, especially if they are new to it as a new clinical task they've never done before, is reading the guidance and undertaking the training. So that has been set as the ideal pathway, but not the only one. So it needs to be a personal reflection of what your kind of level is and what you're able to do and your scope of practice. And then that needs to be in agreement with your employer and place of work, that it's then a task you can undertake. And if it's about proof and evidence, then absolutely the training, passing the assessment and getting the certificate at the end of it is the best, simplest, easiest way to do that. But there will always be other avenues where people, it will almost be a retrogressive step for someone to do that when they've done the role for so long in another guise. So it does allow for some of that flexibility. But I hope that provides an answer that's easy to understand.
Yeah, absolutely. Thank you. Okay. I've got one final question for you all, and that is really, I'd like you to sort of share your opinions and your thoughts on what we feel the sort of future direction for the use of the Fit Note is going to be. So Sarah, would you like to start with that one?
I think obviously it's like David said, we've got to look at things on a local level. So there's only going to be a certain amount of national guidance and, you know, not necessarily compulsory training. So there's got to be some local agreement so that we can move things forward to a, and I think it's just, again, it's not just about embedding it in systems, it's embedding it in practice, isn't it? It's building people's confidence within your own profession that they have the skills to do that. You know, it's interesting in OT, I quite often have conversations with people who say that they will ask the question about work, but won't necessarily, in an NHS setting, they won't necessarily then do anything about it. In some respects, I'm often saying to people, you know, well, why ask the question if you don't intend to actually do anything about it? So it's about, you know, following through and having those effective conversations about work and how we embed that into all parts of care, you know. And obviously, understandably, we've gone down the primary care route, that makes sense, but, you know, in secondary care, it's about starting those conversations early. You know, we treat really high volumes of patients here from a very acute stage right through their rehab process, and having those conversations from the very beginning and understanding that how actually the sooner you have those conversations, as soon as you start that process, communicating with people's employers, how that can really change things and stop people from re-entering. You know, we have a MSK therapy service here, so it's physio as well, and, you know, our waiting list is phenomenally long, as I know is a national problem at the moment, and so many re-offenders, as I like to call them, that are just constantly coming back and using the system. So actually it's looking at it differently, isn't it? And I think that's a real positive about, you know, looking at work as a health outcome, and actually, you know, starting those conversations really early on and influencing that. If we can get people into the workplace, like David said at the beginning, then they're less likely to come back into systems and constantly use the services over and over again. So, you know, actually signposting to people who can have those work conversations earlier in the pathway is what we've pushed for a very long time. And I think Fit Notes allows that, and highlighting vocational rehab and highlighting how therapists and AHPs generally can influence work, and you know, is a really important part of it. So it is about getting it embedded into systems, but it's much bigger than that as far as I'm concerned. And it's, I feel like we've needed this for a very long time to really change. You know, we've got high volumes of musculoskeletal patients who don't go to work, and not many people within NHS services really focusing on work as part of their outcome.
Right, thank you. Kathy?
Yeah, we need to see the figures changing. I think it's 7% of completed Med 3s over the last few years have actually ticked the box that they may be fit for work. So 93% are being signed as unfit to work. That's got to change. We've got to get those messages across to everybody that work is good for you, that work is in itself rehabilitation, and it can only move one way, it can only get better. And we've got to just tap away constantly and improve these messages. And I think these changes to the Fit Note will facilitate that. So it becomes the normal expectation that people get back to work when they have an injury or through illness, but they're supported in that with these effective conversations with the workplace and the organisation. So it's got to become standardised and commonplace and the norm. And I think we're sort of at the lower stages of making that happen. So it's got to be positive, but we've got a long way to go to get things right.
Thanks, Kathy. David, have you got anything, any final thoughts, anything you would like to add?
Only to give a flavour of sort of some from central government where we think this is going. Although a huge thank you to both Sarah and Kathy for those reflections, because I honestly couldn't say it better myself. I think for us, and I think you're absolutely right, Kathy, we need to see, and we want to see that shift in the use of the Maybe Fit, so that, you know, there are a number more Fit Notes that are saying, you know, with these adaptations and with this advice, you can have a conversation with your employer and you can stay in work, or you can get back to work more quickly. But we obviously need to look at this very genuinely, and having made the change, we need a period where this is embedded and implemented, where we observe and learn from that. So we've got plans over the course of the next year to carry out both qualitative and quantitative research and analysis to genuinely monitor what is happening, but to also gather views and to explore what the barriers are to successful implementation, maybe generate some case studies about where it's being done really well, and then to use that as a kind of positive feedback loop to further support implementation over the course of that year. Then obviously at the end of that, so at the end of 2023, we should be in a really good position, you know, as government to say, right, we implemented these changes and this is what impact this has had, so we can then consider further policy development in the future.
Thanks, David. Fantastic. Mandy, have we got any more questions, or is that all of them done?
No more questions in the chat, but I see Anne Harris has got a hand up. Maybe Anne can come off mute and share her question.
There you go. It goes back to what you were saying, Sarah, about an OH nurse saying that they didn't think it would add any value to their practice. You know, I'm disappointed about that because I think it depends on the OH nurse and how they do practice. And when they were talking about expanding who could and couldn't sign fit notes way back in 2017, I think it was, there were some people such as myself who said, oh, I think this is a brilliant idea that nurses should be able to, and occupational health nurses in particular, because of their knowledge of working health and so on. But a number of people countered that by saying, be careful for what you wish for, because you might find a queue of people just wanting fit notes, which I can fully, you know, I can see that point. But I think we need to define what the parameters are of our practice. So I might see an individual with a health problem that they really should be off sick. Rather than them having to go and see their GP to get a fit note, I could give them the fit note plus the normal occupational health report that you'd normally be giving. But I would not want to have a queue of people at my door saying, oh, I need a fit note, I've got a cold, that kind of thing. Does that explain the hesitance of the person you were talking to?
Yeah, and I think it's the same for everybody, isn't it? You know, people are quite apprehensive about, you know, there's a lot of new jobs, isn't there, in primary care networks for OTs and physios to be working with people, and now this acknowledgement that you can write fit notes. I think people have said to me, I'm quite concerned that all of a sudden every single person that asks for a fit note is going to be bounced to the OT because of this now recognition that they can do that. And I think people are quite apprehensive about it being a constant stream of people, but you know, and it is about those localized agreements, isn't it, and setting parameters. I think that's the really important
it's
part.
Like anything, you might have the authority to do something, but it doesn't mean to say that you choose to do it.
That's right. And I think it's about the skills, isn't it? And that's when you're talking about the training. Anyone can go and do the training, but you know, you've got to be somebody that's able and willing to affect a change. Otherwise, there's no point in anyone else being involved in it. Because if all you're going to do is sign someone off sick and leave the narrative section blank, then we may as well stick with GPs just writing all the fit notes, because we're not going to influence any change, and we're not going to. It's about using recommendations, isn't it? And one of the apprehensions I think that from OTs when I've spoken to them is about how do you predict timeframes and how do you make recommendations that are going to really be effective? And that's part of the training. And it may be that some of that needs to happen at a local level rather than a national level, but you know, for some consistency, isn't it?
I'm particularly pleased that nurse practitioners in primary care can sign fit notes, because they can sign a prescription if they've done the appropriate training for quite high level drugs, and yet they now can say that you weren't fit for work, which is just crazy. They'd have to then refer back to the GP. But I think it's a really good step forward for all healthcare professionals.
Thanks, Anne. Thank you, Sarah. Everyone, unfortunately, we're going to have to draw it to a close. We're aware of time. We've probably already run over a little bit, but I just want to say a huge thank you to the panel, to David, Sarah, and to Kathy for your time, thoughts and opinions today, and for all of you for joining us on our first question time for Work and Health session. So if you have any feedback, please do let us know, because it's really useful for us going forward. But we do plan to do a session similar to like this after each of the council meetings. So there will be some different topics. But in terms of this topic from the FitNote, it's been fantastic to discuss it amongst different professionals, understanding our opinions. Overall, it sounds like it's a very positive move, and it's going to really help us with increasing the conversations about work and health and raising the profile of occupational health as well. But it does sound there's a little bit of work to do in the meantime, but at least we all sound that we're on the sort of same page a bit. So we'll keep the discussions going, and like I say, please do let us know if you've got any feedback. Okay, but I'll thank you all for attending today, and we'll see you again.
Thank you. Bye.
Bye-bye.
Going to stop recording now.